What a wonderful discussion. Would you agree? As we wrap up the formal discussion part, I was taking notes all throughout, and I'm sure several of you were as well. And I'll make a few comments just in terms of what I heard in terms of recommendations, and then we'll open it up for an opportunity for folks to ask questions. Looks like we have some people lined up, so I'm excited about that on that piece. But starting with what we heard from Joanne, certainly the opportunity for us to be able to capture roles better and have some accountability to some economy, some taxonomy, if you will, on those roles is important. And of course, addressing the payment rationale opportunities there. With Angelina, we had the opportunity to really hear passionately about valuing home care work, which I think was so important and so poignant, and how she delivered that. Several things I wrote down from her about really articulating that it's middle skill work, and that we all have an opportunity to really uplift this work that much more and be advocates for it so that we can address issues of wage incongruency, job quality, et cetera, which was really powerful. Valuing the other who tends to work in this space, be it a person who's a woman or color, or different ethnicity, or from another country of origin, and that we can have the opportunity to train to do more and then measure that impact, which could be a nice lever then for opportunities for payment. From Amy, Power for Work and her organization, they really appreciated that dialogue. A couple of things. One, about there being no federally mandated competency for some group of that, and that really seems like a great opportunity for advocacy there. But certainly the admonition for us to integrate care teams across the healthcare system that much more and professionalize the direct care workforce. I love that. I love that phrase. And then lastly, from Loran, I think the video was a mic drop there in terms of how we might be able to really uplift a model of care delivery across systems, and really articulating how to involve the person we're serving as part of the design, and always remember to ask what matters most. So thank you for that rich contribution. With that, I'm going to invite people to ask questions and remind you to please state your name and the organization that you're with as you're starting to ask questions, please.
Thank you. Denise Hess, Supportive Care Coalition Association of Professional Chaplains. This is not my question. This is from Jennifer Ballantyne, who was on this morning's panel and has emailed me this from her location. This is for Joanne. She's asking, how do you see the recently passed bill in California reclassifying large categories of, quote, contract workers as employees affecting this sector? Good or bad for workers, good or bad for employers?
Oh, that's an excellent question. For those who aren't familiar with it, the bill was largely aimed at like Uber, Lyft, and DoorDash. But for workers in the long-term care setting who may be pushed into kind of, the number of times I get a phone call from a business school student who wants to, be the Uber for home care. It's like, oh dear God. But that there are opportunities there to create some worker protection in those classifications. Especially from the perspective of agencies. In the case of the agencies are generally the conduit that are assessing patients, determining needs, and placing caregivers into those roles. And so from that standpoint, that is a very different, maybe not a very different arrangement than what Uber or Lyft are doing. Mm-hmm. So it'll be interesting to see how that plays out. The other piece in California that's a little bit, that might be a little bit unique is that for our in-home support services programs, which are a consumer-directed program, some workers in those programs are union represented as well, which is another vehicle by which protections can occur, and where there have been efforts among some of the unions as well as other providers and organizations to try to create that upskilling opportunity, including a federally funded pilot program where they were training individuals to really be part of the care team and communicate with the care team. It wasn't a huge study, so an evaluation, so the power calculations are weak and all that, but the results were really suggestive in terms of client satisfaction, worker satisfaction, lower emergency department visits, although, not statistically significant because of the numbers and so on. But I think it was a really nice example where you could bring together a coalition of people to move that forward. And that kind of work, I think having regular employment relationships is very helpful to moving that kind of endeavor forward. So we'll see how it plays out in California. That legislation, I'm sure, will be litigated because Uber has a lot of money to do these things. But it could have some interesting spillover effects in a positive way towards this particular sector.
Great, thank you.
Thank you. Next question? Please. Yep.
Hi, my name's Hannah Elise, and I'm from HRSA. And I think I just had a comment, and very brief, and then also a question. Someone mentioned that a lot of the folks that work in home care are invisible, or that people don't know about them until a need in the family arises. And I would say that that's definitely the case for me and my family. We had to have a home care worker to care for my grandmother after she fell and injured herself, and we had to have a home care worker come to our house for several hours a day, every day, and that was really the first time that I had ever thought about people in that profession or had any sort of exposure to it. So I agree with that sentiment. And my question is for Ms. Drake. You mentioned that you think that a lot of the moral arguments for improving the circumstances of home care workers have been ineffective, and you advocated for more of a business approach. I was wondering if you could elaborate a little bit on why you think that the moral arguments have been for improving the lives of these people given that there are so many of them, have been very ineffective, and if you could elaborate a little bit also on the business approach arguments that you think are effective. Thank you.
Sure, and thank you for the question. I should note that there have been wage gains in this workforce. They've been very meaningful, particularly when wages are this low. The changes, the home care rule to the Fair Labor Standards Act that meant that home care workers were subject to minimum wage and overtime protection is significant to this workforce. But these improvements have been long fought, and they are incremental, and they are insufficient to addressing the workforce needs and the significant needs to improve job quality. I think this moral argument relates to a lot of things that are deeper in our culture around care and who we assume should do care or can care. There's these ideas that anyone who does this well, despite the current state of the system, is a saint or an angel that are still really pervasive. It's this idea that if someone's doing this well, they must inherently want to, and I think that relates to a lot of people's expectations surrounding gender and other factors with this care, and that's a difficult thing for folks to talk about. Like your family, mine is affected by this too, and as much as I know about this industry, it is a lot of work for me to support a female family member who's had to drop out of the workforce and temporarily leave her kids to go look after my grandparents. And it's something that every family is facing. There's a workforce shortage in their area. We're all sort of being confronted with this, and it's a ton of work just to figure out what supports are available. I would also say that we don't like to address issues of illness, limited mobility, death and dying. This is also why this moral argument has been a difficult one to make, because it's just a difficult conversation for us to have.
Thank you. Next question.
Sure. Phil Rogers, American Academy of Hospice and Palliative Medicine. My comment actually dovetails nicely with that, and you answered a question I was about to ask. Anyway, I would sort of put maybe one more item as a question out there for consideration around this issue of wage and direct home care work. And I want to underline the importance and the kind of the magnitude of this gap and how much it really gets in the way of the care we all would want for ourselves and our loved ones. Even in the hospice benefit, which is probably the richest home care benefit available, there is very, very limited direct care that can be provided through that benefit in the COPs. We have this discussion with patients and families every day when we're trying to recommend hospice care. When we can talk about the interdisciplinary team, we can talk about the 24/7 access. But we do also have to have a very specific conversation about how the hour-to-hour care falls to the family. And that can be, and if they can happen to afford to pay for that home health aide care, that could work. But of course, we know so many families can't, which kind of leads into my question. I wonder if the state of the payment for home care, this kind of mix of some benefits through Medicaid, but a lot of out-of-pocket cost, a lot of stuff under the table that's probably not being reported, how much that plays into downward wage pressure, and where you see the potential levers to professionalize this and pay for it as we do through other services, some specific ideas about how we may begin to advocate together for kind of a system that helps kind of support the payment for that this work deserves.
I can make a couple comments on that. I mean, one is that the separation of the different programs is problematic. There are a lot of states that I think recognize that higher pay and better working conditions would reduce turnover rates, and we have a lot of reasons to think that the continuity of care would have positive downstream cost savings. However, if Medicaid is paying for those services and you avoid a hospitalization, Medicare gets the bulk of that benefit, right? So for the state, they could invest all this money in something and they aren't going to get any return on investment for it. And I'm an economist. Return on investment matters, I mean, to some extent. And so things that you would want to do that are super obvious don't happen. And we're seeing this we're actually seeing some impact along these lines at the local level. San Francisco City and County has actually put some money into a pilot program that they have now decided to keep permanently, that is offering vouchers to support the purchase of home care services for what they call middle income seniors, which means, you know, in San Francisco, you could earn $100,000 and still not afford a home care service. And it doesn't, you know, it's limited hours depending on what your needs are. It doesn't go over 20 hours a week of services, I believe. But and you have to make a co-payment that varies with your income. But for individuals for whom this seems very unaffordable, it is, we are seeing in the data statistically significant declines in hospitalizations, emergency department visits, and even primary care visits, which a few researchers have argued are kind of an indicator of whether home care needs are being met, is that people don't have to go to the primary care provider over and over again. And the city is not going to really get the return on investment for that because of the way the financial systems are structured in healthcare, but they're willing to do it because they believe it's valuable for the city. And I think that's the economic reality, is that the financing systems are going to keep driving these things, even though there is every reason to believe the economic argument that Angelina says, okay, if we can't get the moral thing, let's try the economic thing, that argument we should be able to kind of win. But we need to get those structures organized and talking to each other. Dual eligibles are a great opportunity in that regard.
Thank you.
Yeah, and I would just add also to the prior question about the business case, this idea of aligning incentives across different funders has to happen, even to make the business case at the employer level, because most employers aren't affected if they're driving down hospitalization rates, right? So they have to have partners in place. They all have to agree around the principles here and be looking for their own economic outcomes in that mix, which for employers would be retention primarily and recruitment. But it's bringing those together. So it means aligning a lot of partners around this. It means getting more study. This area is pretty understudied relative to other health professions. So we have to get that data out there. We have what I would call the blueprint for a business case, but we don't have enough data and access to enough partners to fully flesh that out and make it. We're in the process of trying to, but it gets really difficult. And I think that these models that you've mentioned are really promising because they show that kind of alignment, and you get the larger system to really care about one area of cost savings because it's going to drive improved quality of life across the larger system.
I just want to add one comment about innovation. So one trend that I'm seeing that's lovely is that very large insurers are becoming interested in this for a different reason. So large private insurers, their clients are employers. Employers are seeing the impact of the stress of caring for family members on work absenteeism and illness costs. So large insurers are starting to get very interested in what is a sustainable system for providing this care, and maybe new partners to think about.
Thank you all.
Great. Thank you for the question. Another question on this side?
Marion Grant again. Just building on what everyone has discussed, I recently took care of a patient who has been living at my hospital in downtown Baltimore, a major shock trauma center, for several weeks, has a chronic wound, very debilitated, is miserable in the hospital. And we were having conversations. They sent me in to talk to him about hospice, which was not where he wanted to have that conversation. But had I had that conversation, I would have had the same problem that Phil would have had, which is the family was going to need extensive help wherever he was going to go home under whatever circumstances it was. And he was so frustrated. He was crying while I spoke with him. And he said, I just don't get it. And because I wear a policy hat in addition to being a clinician, I said to him, you know, here's the problem. The insurance company is willing to pay the thousands of dollars every day that it's costing to keep you in this hospital because we don't have a comparable infrastructure to care for you at home. That will fall on your family not only to pay for, but to coordinate. And his elderly mother separately stood in the hallway with me and said, we don't have the money, and we've tried to call. But his wound care was quite extensive, and you could see how you'd have to cobble together a home health nurse, a caseworker, a social worker, home health aides, round the clock for the guy, at least initially. It was impossible. And yet, I walked away from there thinking, this is ridiculous, because meanwhile, the meter is running, and his insurance company, or his wife's insurance company, and they aren't very close, but they're still married because he needs her insurance, is paying for all of this. And it fuels the recognition that we not only need to have the data that shows the benefit, but we need to build the infrastructure so that you could go to a payer and say, you're spending $7,000 or $6,000 a day, whatever it's costing. I could get care for you at home for half that, but I'd have to be able to give him a network that already existed. So any other thoughts on that would be appreciated.
So I think that's one of the most exciting areas I see because I'm working with these different systems to design models. So obviously we tap into those cases and then we're negotiating. So what happened in Lake County, this collaborative, in intervening with people, learned they didn't have a place for people to go. So they opened a 10-bed transitional housing place called Restoration House. Then they learned, so the outcomes from that, they had a place for people to go to get comprehensive support. It's not a nursing home. It's run by a minister and students. And the people who live in the house, as they become more stable, become peer navigators. So they learned from that then that there was another need for a coordinated place that had the providers sharing space and co-locating for complex issues. And there's also a housing, like a complex housing component connected. A payer gave them $1.3 million to open that. The funding for these kind of programs are coming from different sources. The cost reduction for EMS, criminal justice, multiple agencies is generating new revenue and new solutions, and then local foundations are seeing the impact on their community and are another revenue source. So there is hope, but it takes having sort of a navigator, an instigator, partnered with new ideas about how to do it, but the evidence is emerging. And that having a place, like a micro community with support that's affordable and outside of the long-term care environment is one of the emerging trends. Yeah, no, we wanted to be somewhere, and it's possible to do that. It's being looked at more with people who are homeless quicker because you can't send someone on the street who needs wound care, and you can't get that in a shelter. So those kind of solutions are emerging a little bit faster, but I see them coming.
Great.
I would also say that I think there are a lot of opportunities for us to really look at the AAAs the area agencies on aging as centers to help us provide these services, and they're starting to do that. But they need the additional funding. They are also looking at developing and expanding the programs that they're providing that are not just Older Americans Act funded programs. And I think there's a lot of opportunities because they're in every community for us to partner, at least partner, but also they can be the ones leading those efforts as well.
Great, thank you. On this side, we have a question.
I think this is probably more a comment than a question. My name's Terry Maxwell. I'm Chief Clinical Officer for Turnkey Health, and thank you. This has really been a very enjoyable and interesting panel. And as I was thinking about it, we provide community-based palliative care services to seriously ill people, and we use nurses and social workers in the community to be able to do that. And as we're listening, we're hearing about all of the social determinants of health issues, and this is constantly what we're finding is people with food insecurity and poor health literacy and no transportation. And yes, sometimes they have symptoms, but we have doctors that they already have that we can call to let them know that their symptoms are escalating or whatever. And trying to coordinate all that care, yet all of the payment policies that I'm seeing that are being put forth by all of our palliative care organizations are still sort of stuck in a medical model. And they're still requiring physicians and nurse practitioners to be sort of the leader of the team to go out and make these home visits when I don't really know if that's the right skill set that is absolutely required for all of, in order to get paid, they have to be seen by a doctor or a nurse practitioner, whereas maybe they just need to be consulted occasionally by a doctor or nurse practitioner. And I think we're setting ourselves up for failure because it's inherently not scalable based on all of the data that we saw today. So I kind of think we need to put our heads back together and think about what are the real problems that people are experiencing, who are the people that are best suited to manage those problems, how do we compensate them fairly, and how do we work as a team to achieve really good outcomes for people. So I don't know, that's more of a comment, I guess, than a question, but I would love to hear anyone's reaction to that.
Yes, that's it exactly.
There's also a real opportunity for advocacy, and I don't know if the panelists want to comment on that piece too for payment reform. But Amy, yeah.
So I would say that the thing about many of the things you mentioned are determined at the state level. So it requires state level advocacy, which is complicated for us at the federal level. We have a two-person team. So we're happy to consult and talk to you about what's happening at the state level and try and help make changes, especially in scope of practice and how we're developing these teams when there are teams, because many times there aren't even teams. So, but it is complicated by the fact that it's 50 state legislators or legislatures.
I was just going to add a comment. So one of the things I see changing that dramatically is ACOs and all the value-based payments. So all of a sudden, if the impetus isn't around increasing billable visits, then all of a sudden, magically, other people on the team can be leading this. And I've been part of, building these programs for a long time. The other thing that I think is really interesting that I think we can't forget, and because of the National Center, people call all the time and we'll talk to anybody for an hour as part of field building. So in the last week, I spoke with the sheriff of a county in Tennessee who's starting a collaborative. And it's all agencies, but it's to look at complex needs in that county. I also spoke with a city councilman who's looking at his district and wants to set up an ecosystem. Like the sources that are starting to get interested in this are outside of our normal lanes that we think about. And that to me gives a lot of hope because there's other funding sources, there's other partners, and then there's other opportunity for creativity in the delivery.
I would add to that, there's a lot of opportunity for professional advocacy, especially when you start talking about scope of practice and who owns what. And recognizing that so much of what needs to happen is not in the medical realm per se, and maybe not even in the nursing realm per se, although nurses are more broadly deployed across the health system. The degree to which clinician leaders, any health executives, any kind of healthcare leaders are willing to step out and say, you know what, everybody needs to have their hands on deck. There is more than enough work for everybody. Allowing a home care aide to be involved in medication administration is not going to hurt my job. And that those kinds of efforts need to take place. Because there's still even a lot of states, including my own, where if a client wants to have Visine put in their eyes, their home care aide is not allowed to do that. That is illegal because it's medication administration. And then you'll encounter, nursing organizations press against allowing that because they view it, they argue on the patient safety standpoint, but it's like, yeah, but then the client instead is going to hire somebody off of Craigslist who has no nursing engagement at all. Like there's plenty of room for all of us here. So I do think everybody here who's in a clinical role, anytime you hear one of your colleagues say, oh, those unskilled blah, 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 we could never let our state legislature change the regulation to let them do blah, 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 please dress them down. It really is a responsibility that we all have, and they ignore me because I'm an economist. What do I know?
Thank you. Did you have one more comment, Angelina? Yeah.
In addition to the role of regulating the professions, the need for advocacy there just cannot overstate the importance of public funding in shaping workforce conditions in this field. So the solutions have to be advocacy-based here. Medicaid sets the norms that the private payers tend to follow in this field, and so we have to have advocacy. If we look at other campaigns that have increased wages for workforces in retail or fast food, it's been a different equation there because they have, as we found out recently, lots of corporate profits at the top of those companies that can be redistributed back to the workforce. That's not the case with long-term care and with home care services. So that same type of organizing isn't going to work in the same way if we're not appealing to legislatures and to this public funding mechanism.
Yeah. Thank you, Angelina. We have one last question. A gentleman's been waiting patiently here before we wrap up.
Patrick Ross of the Joint Commission. You may have actually just pre-answered my question, but you've talked about the benefit of upskilling, this need for additional training to kind of deal with the medical nursing skills that are used day to day. I'm wondering if you have recommendations on how to get that done, knowing that simply just adding another training requirement up in front create another barrier to entry and exacerbate a workforce shortage.
The workers that I know would love to have these skills, and they want to create impact for their clients. So it's having quality, accessible training programs that are adult learner centered, that include practice for these skills, so folks know the type of job that they're getting into and that they feel well supported. And then it's adding value to that job with things like peer mentorship, strong supervision, again, all the aspects of job quality that would go into it. I actually don't think implementing the training, we need funding for that, and that gets to be a really difficult thing. But in terms of workers' acceptance of training, that tends not to be limiting. The power in the pilots that we've done where we have workers who feel like they can see the impact that they're making on their clients is really important, and the power of them being listened to. Some folks have been in this field for decades, and for the first time in these pilots, they're being listened to, and what they observe about their patient is making a real difference. And so it's critically important to them, and I think you'd be able to get them on board for this work.
I would add to that, look at Washington State as an exemplar in implementing career ladders, training programs, all aimed at home care workers, with the belief that that is going to be financially, cost saving and be better for the workers that they're supporting. It includes mentorship, apprenticeship, and the whole thing. It's a great model.
They're also paid when they're training, so that's another key to it, is that they don't have to take a day off of
Very good. Thank you so much. What a robust discussion about our workforce for community-based care. I'd like to thank the panelists again, Dr. Spetz, Ms. Drake, Ms. York, and Ms. Harden for a robust conversation. Thank you for your attention.